I'm going to talk about 3 questions pertaining to COVID-19 epidemic models, as the title suggests. And my focus is really going to be on the questions rather than their answers, because I think COVID-19 epidemic modeling is an underexplored area. I mean, to some extent that shouldn't be surprising because COVID-19 is new, it's only a year old and philosophy moves slowly. But I think epidemic modeling and infectious disease epidemiology generally is a under-theorized, understudied area. So I'm hoping there'll be more work in this area because it poses interesting problems, both old and new, for modeling and philosophy of science. So really I could have asked a bunch of questions, but I'm just gonna choose 3 here that are all linked because they have something to do with causation. So the first question is, what kinds of predictions do epidemic models make? Then, are they causal models? And finally, do different kinds of epidemic models represent the same phenomena? Okay, I asked these questions in a short discussion note in History and Philosophy of the Life Sciences recently, so you can check that out. And here I'll be offering some tentative answers. When I'm talking about epidemic models, really I mean what are sometimes called transmission models, but even that name is often applied more narrowly to a subset of the kinds of models I'm talking about. So I mean models that are used to represent the spread of the infection in a population and either explain or make predictions about what might happen. Okay, so this includes things like curve fitting approaches, agent-based or micro-simulation models, and compartment models. Briefly, curve fitting models are statistical approaches in which you take a look at the data from an existing epidemic in another country, let's say. You try to fit some sort of function to that data, some sort of curve. You might then apply that to a new context to which the epidemic is just taking off. And then you try to figure out where are we in the course of that curve in our current context, and we extrapolate forward. Agent-based or micro-simulation models are pretty new as a modeling approach. Over the last 20 years, they've become more popular. They're massive computer simulation models that can end up modeling the movements and infectious status of up to millions of people in a population. So of course, the most famous initial Imperial College model was an example of this for the US and the UK, but there have been many other examples. And these essentially track the individual infectious status of simulated individuals as they move around the course of their day, separating environments into workplaces and homes or schools, separating people into different age groups, and so on. And so then from there, you can just aggregate up at a given moment how many of those simulated individuals are infectious, susceptible to infection, and so on. Compartment models, number 3, are actually older. They're equation-based models. They're over 100 years old. And they do the same thing as agent-based models in a sense, except that they don't track individuals, they track compartments or subpopulations. So they ask the question, okay, so how many susceptible people are there at a given time? How many infectious? How many recovered from infection? And then they track the changes in the sizes of those compartments as the model evolves. Okay, so on to our first question. What kind of predictions do epidemic models make, including the ones used in the COVID-19 pandemic? And here I won't initially draw the distinction that I just raised. Those 3 kinds of models, that'll be more important for question number 2. But let's just take them all together and ask, what are the kinds of predictions they can give us? And a common distinction is made in this area between forecasts and projections, although the terminology isn't that standard and sometimes it's used confusingly. So forecasts are sometimes called predictions. Andrew Schroeder, in a short article in our journal, Philosophy of Medicine, recently helped to clarify the distinction this way. So we can think of forecasts as being unconditional predictions and projections as being conditional predictions. And so actually, I'm just going to prefer to talk about unconditional predictions versus conditional predictions because that terminology is straightforward. So unconditional predictions are something like 2 million people will die. Okay, this is going to happen in the actual world. Projections, or what I'll call conditional predictions, are 2 million people will die if no anti-contagion policies are implemented, or if some other antecedent is attached. So they're conditionals, right? They have an antecedent, a consequent. They're not necessarily saying that this will occur only if no anti-contagion policies are implemented. This distinction is usually applied to models or modeling outputs. Behavioral scientists and epidemiologists often do this, and they'll speak of projection models, by which they are often referring to things like agent-based or compartment models. Schroeder goes along with this distinction and asks, when we look at the Institute for Health Metrics and Evaluation model, a famous model in the US, also cited around the world, and we turn back the clock to April 2020 when the model was new and in its first iteration and making some of the first dramatic predictions in the United States, what kind of prediction was it making? In particular, in April of 2020, it made this prediction that was widely reported in the media, talked about at a famous White House press conference, that 60,000 Americans were going to die by the end of May 2020, whether we liked it or not, assuming that states that had already implemented social distancing continued to do so, and that the ones that hadn't quickly implemented social distancing measures. Okay, so according to the White House, this was one of the projections that led to their policy to recommend lots of different restrictions. And so Schroeder wants to know, is this an unconditional or conditional prediction? And you can't just go based on what the wording that the IHME is using, unfortunately, because they use terms inconsistently. If you look at the current website and the current version of the model, which has evolved quite a bit in the last year, they sometimes use the term projection or forecast to refer to the very same figure. So they don't use the terminology as it's somewhat standardized in the literature. So that's not a helpful indicator of what they're trying to do. And so basically Schroeder concludes that there's mixed messaging here. So on the one hand, initially, at this time, one of the main tasks for the model was to help us predict how many hospitalizations and deaths there will be in order to help hospital resource people figure out shortages of ventilators, beds, and so on, and help coordinate healthcare needs. And that's the kind of task that you would think that a forecast would fulfill. On the other hand, Schroeder made a lot of, paid a lot of attention to the title of this page and what was repeated throughout the website at this time, that COVID-19 projections were being made assuming full social distancing through May 2020. And so he points out that if there's this assumption, that's tantamount to attaching an antecedent to this prediction. So he ultimately concludes that they were making not a forecast as most people assumed, but instead a conditional prediction, right? A conditional of the form, if full social distancing, then 60,000 deaths. Okay, I think this is not a not unreasonable way of interpreting this claim that's being displayed and broadcast by the IHME at the University of Washington. But my tentative suggestion is that I'm not so sure it actually makes sense to apply this conditional, unconditional prediction or forecast projection distinction to the level of the model and its outputs. After all, if we're taking it that projections follow from certain assumptions, then all models make assumptions in the form of the parameters they adopt or the structure of the model. So then it seems like all models are just making conditional predictions and there's no use in drawing this distinction at all. Moreover, a model doesn't know whether or not the relevant assumptions obtain, right? If I'm a model, I don't know whether the structure and parameters that I'm representing apply in the real world. So in that further sense, I don't think it quite makes, I don't think it's quite clear that we can say that a model sometimes might make forecasts and sometimes might make projections. But rather, I think models simply do operations over inputs. That's all they're able to do. And then model users take those outputs and they may or may not attach an antecedent to them. So they may or may not use those outputs to make a conditional versus an unconditional prediction. So that's my tentative suggestion, that this distinction is actually best applied at that point at which model users turn model outputs into unconditional or alternatively conditional predictions. Okay, so then we can say that rather models are simply projecting from assumptions. And then to go back to Schroeder's question about IHME, what was it doing? What were the modelers doing when they were making this prediction? Well, I think it's fair to say that maybe they were unclear about, maybe it was unclear to the world, or maybe they were even unclear about what they were doing. But one possibility is that they were making this projection, handing it off to others, so that later on, once various states made decisions about what policies to implement, people could then plan accordingly. So it's kind of like a conditional prediction that you could kind of put in your pocket and then turn into an unconditional one based on what your state does. Because although I'm showing United States-wide predictions here, they also broke it down state by state. Okay, So the second question I want to begin to ask is, are all of these epidemic models causal models or not? And here I think it is important to distinguish among the three different kinds that I initially brought up. So I'll start with what I think are the two easier cases first. So curve fitting approaches, they're statistical data-driven approaches. Sometimes they use regression, sometimes they use other strategies. And I think we can say that curve fitting approaches aren't intended to be causal models any more than if we were to plot a curve onto a graph where on the y-axis there was rainfall and on the x-axis there was barometer readings. We should take that curve and the function representing that curve to represent causal dependence. A curve could fit well to a data where, while at the very same time, its variables don't represent a causal relationship between the y and x in either direction. So I don't think they're intended to be causal models, and I don't think we should take them as such. But on the other hand, I think the other two kinds of models that I talked about are at least reasonable candidates. Okay, so here is a nice simulation by the University of Washington of an agent-based model, which tracks billiard balls bouncing into one another, where the orange billiard balls are infected people, the light blue are susceptible. You can see over time through interactions, the oranges become, the blues become orange and then purple as they recover. This is simulating a small epidemic. And an agent-based model is being used to generate this. Okay, so agent-based models, I think, have a good claim to being causal models for a few reasons. So on the one hand, they're modeling what seems to be a causal process. So infection transmission is a causal process. I infect someone else, hopefully not. That's a causal process or event. And I think we could even, following Marius Maziarz and Martin Zak, who had a nice piece in the Journal of Evaluation and Clinical Practice last year, in calling agent-based models mechanistic models, because they capture three key components that are often attributed to mechanisms by philosophers in philosophy of science. So they model the entities, namely the individuals and their infection status, the activities, namely transmission events, and the organization of this overall thing, namely the spatial and temporal organization, the causal organization. And together they show us how these various components are responsible for some wider phenomenon, such as the evolution of an epidemic at a population level when you aggregate up. And they capture all those elements in the model. So therefore, I think we do have some good reason to think that these agent-based models are mechanistic models. Okay, and because mechanisms are typically thought to be causal things in the world, those models that are representing those elements, I think, could also be considered causal models. What about compartment models? So while agent-based models, as I mentioned, capture the individual movements of people and their infection status, compartment models aggregate up. So they're just tracking, for instance, the number of sick people over time, or the size of the sick compartment, the number of susceptible people and how it changes over time, and so on. Now, these are sometimes called mechanistic models by modelers, but I don't think we should necessarily, from that assume that compartment models are mechanistic models, at least in the very same way that agent-based are, because while agent-based models represent these different entities, these individuals and their infection status and how they evolve over time, compartment models are just representing the dynamics of the epidemic. So they consist very simply in a series of differential equations, most commonly, that have as their dependent variable the rate of change in some population compartment on the left-hand side. And then they just relate this to other population parameters, such as beta, a very important parameter, which represents the average contact rate, the rate at which an individual successfully transmits infection to another on average in the population. Nonetheless, I think, even if they're not full-blooded mechanistic models, they still represent mechanisms partially because they represent the dynamics of an epidemic, which is an important component of the epidemic mechanism. Okay, so I don't think we should totally say that they're not models and mechanisms in any sense, but maybe we don't actually need them to be models and mechanisms to consider them causal models. So I think even dynamical models are potential candidates for causal models if we adopt a more minimal understanding of what it takes to be a causal model, as I think we should. So in a paper last year, Russell Meyer in BJPS applied Woodward's manipulability criteria to dynamical models to show how given certain conditions, we can consider dynamical models to be causal models, namely if it's the case that we take certain manipulations of variables in the model to represent causal interventions on that variable, and then are able to track certain changes in other variables accordingly. So it's about manipulating variables and generating counterfactual predictions, and then comparing these different counterfactuals to determine if there's a difference made by manipulating that variable on the right-hand side of the equation. And so what I think is that this is exactly how these compartment models have been treated by many modelers over the world, as models that are available to us for producing certain manipulations in order to make causal predictions about the results of interventions. And on the basis that these kinds of manipulations tell us about causal dependencies via the right kind of counterfactual dependencies and relationships, I think we can consider these models to be causal models. So in summary, my tentative suggestion is that compartment modeling attempts to represent causal dependence of epidemic dynamics on various parameters. And the evidence for this, the chief evidence that they're used this way, is that modelers have intervened on these models, manipulated parameters in order to generate causal predictions. So here's a graph from a famous paper way back when, March 26th was the report by Imperial College London, where they applied an SEIR model to 200 or more countries in the world. And then they manipulated beta parameters of the model and saw how the epidemic would evolve accordingly. Okay, so 2 questions down. The last one I'm actually going to spend a little bit less time on because, and paradoxically, because I spent the most time thinking about it. So it's perhaps the one that least interests me at this point going forward. It's the one that I'm less sure about I'm more sure about what the answer is. So there's less to be gained by discussing it at this point. So the question is, do different kinds of epidemic models represent the same phenomena? So I showed here 2 possible models side by side that seem to be representing the same epidemic here. Are they representing the same things? Okay, so first I want to set aside, of course, the fact that the model at the bottom, the agent-based model, is representing more details. But we can, of course, talk about the top model potentially as just abstracting away from certain details and capturing others. So really the question is, are there shared features, important shared features that both of these models are capturing? And if we want to make it even more specific than that, the question that I really want to get at is, are they representing the same causes? So when the bottom model appears to be representing causes at the level of individuals and representing something like disease transmission in the population, what is the top model doing? What is the compartment model doing? It's obviously not representing individual disease transmission events. But on the other hand, it has parameters like beta, which abstract away from or coarse grain over individual disease transmission events, but nonetheless represents these events just at a population level by abstracting away over the individual happenings and giving us a summary of what's going on at the population. But when we're talking about the actual causes in the world, I don't think we should say that beta represents something different than the individual disease transmission events that are captured by the agent-based model. It's just that they're representing it at a different grain of analysis or a different level of abstraction. And in fact, I don't think it really would make sense to say that the agent-based model is representing different causes than the compartment model, because the compartment model is representing population parameters like the incidence, which simply aggregates over cases. So you can run a sort of thought experiment where we introduce a new case into the population. There are obviously some causes of that case. At the very same time, the incidence is going to tick upward by 1, but the only causes that we've introduced are the causes of that case. So in some sense, because the incidence aggregates over cases, the causes of cases in the population have to be the same as the causes of the incidence, unless we're going to strangely introduce new causes that only operate at the population level. However, you might know that an epidemiologist, Jeffrey Rose, in the 80s and 90s pushed this very influential line that the causes of cases in a population such as infection are different than the causes of incidence. He was mostly interested in non-communicable diseases, but his point was that if you took 2 individuals in a population, what told you, or what explained why one had higher hypertension than another in that population might be a different cause than the ones that would explain why an entire population might have a shifted distribution compared to another. The former case might be better explained by genetics, the latter might be better explained by environmental variables. Okay, so I just want to gesture towards this idea that I've developed, that Rose's principle points to something important, but it has to be amended a little bit. So instead of talking about the actual causes in the world, which I've already said have to be the same when we're talking about the individual events and the population events, the contrastive explanations for cases are distinct from the contrastive explanations for population incidences. So, to explain why the incidence is dropping in the United States, whereas it's increasing in India, you have to zoom out and look at the population as a whole. And the kind of explanation you're going to give might be different than the kind of explanation you might give if you're trying to tell me why, Sam rather than Sally was infected. We're often going to offer different kinds of explanations that are going to focus at a different level of analysis or decomposition. But I won't go into my proposal too much more. So these are the 3 questions I asked and the tentative answers. And because I supplied the questions, I'm hoping that we can have you now supply the answers. So these are just mostly tentative suggestions, but I'm curious as to what your thoughts are. So thanks again.